Good morning, everybody. Dr. Gandhi, we want to go ahead and get started. I think we've got a quorum. Present.
Certainly, Madam Chair. Ms. Walmsley, Ms. Nair,
Here.
Mr. Dang indicated he could not make it today. Mr. Pond,
Present.
Ms. Howe,
Here.
Ms. Fine.
Here.
It was announced at the last board task force meeting, Ms. Nishi had resigned from this task force. I'm taking her off. Mr. Bozen,
Here.
Mr. Morris,
Here.
Ms. Almer.
Here.
And Madam Chair, before we declare conflicts of interest, there was another individual that wanted to join our task force, and with Ms. Nishi resigning, it may be a good idea to add another member. And it's agenda item 4A, consideration of adding Beena Patel to the task force committee. She is with Honor Health and she is on the call with us today.
Thank you. Welcome, Ms. Patel.
Yeah, thank you. Thank you for allowing me to participate.
Dr. Gandhi, do you need a motion for that to add her or?
Yeah, it might help to just,
I'll make a motion.
All right, go ahead, Matt.
I'll make a motion to add Ms. Dr. Patel.
All right, thank you. Do I have a second?
I'll second it.
All those in favor?
Aye.
Aye. Any opposed? Welcome to the task force. Ms. Patel, do you want to introduce yourself to the group just so we can get to know you for a minute and talk about your background a little bit?
Yeah, sure. So thank you again for the opportunity to join this team. So I'm Beena Patel. I'm the AVP for Acute Care Pharmacy Services at Honor Health. I've been with Honor Health for about 8 years, and in different roles, Director of Pharmacy, System Director, and then my recent a year and a half as AVP for the acute care setting. I've been in practice, mostly in the hospital setting for about almost 30 years. I know I kind of shares my age, but different organizations across the nation, Dignity, Catholic Healthcare West. So a lot of experience more in the acute care than retail setting, and just wanted to join this team so that I could bring my experience from the hospital perspective to the rule writing task force.
Perfect. Well, welcome. We're glad to have you. Looks like we might have another special guest on the call too, Kelly. It looks like maybe an intern for you, if you want to introduce your student or have your student introduce themselves too.
Yes, I have Maggie, who's a U of A student, ACCE student on rotation with me.
Hi, everyone. Thanks for letting me participate.
Welcome, Maggie. Thank you. Dr. Gandhi, you want to do conflicts of interest?
certainly, I obviously anyone can just speak up because I don't know if this agenda item really applies because we're going to speak to many things and everyone's going to speak to their interests as well. So we can certainly entertain. I just want everyone to know that obviously the mission of the board is to protect the public, and we got to keep that in mind and do our best to make sure the mission is upheld.
Anyone have anything to disclose today? All right. Dr. Gandhi, do you want to direct me where you want to go next?
Certainly. I think we got agenda item 4A out of the way. 4B, at the last board meeting, we had introduced a subject, collaborative practice discussion clarification, and the board had decided to put it on the task force, and we already have a task force for rules. So I figured it'd be a good opportunity to bring that discussion up. The collaborative practice language has expanded to include group to group agreement. But when you incorporate that, the pharmacist is then left with the task to choose a physician out of that group, and we don't know which physician to choose. So kind of just put it out there, brainstorm a little bit on how we can kind of give direction to pharmacists on how to proceed with this new language.
Kelly, do you want to go ahead?
Yeah, if I could just real quick, since we were the entity that introduced the legislation. So just to clarify a few things, so we worked with the physician organizations on this bill. This was not a scope of practice bill. So all we did was modernize and clarify things that were already existing. So it didn't technically expand or allow for anything new. These agreements had always been between multiple providers and multiple pharmacists. The way it was worded was a little confusing. And so we worked with the physicians to clarify that. We didn't have to go through the Sunrise process or scope of practice because it wasn't changing any of our abilities. So if that helps with that particular discussion. But the reason that that's important is that, in these practices where a lot of these agreements are in place, there's multiple physicians in that office that are operating under the agreement that are allowing their clinical pharmacists that are seeing patients operate under that to the degree that they're allowed to provide the services that are delegated under that agreement. And so they have their own internal procedures on, the physicians that are a part of the agreement and the pharmacists that are a part of the agreement, and they're all following the terms of that, but you don't necessarily indicate a particular prescriber or pharmacist necessarily, as long as they're part of that initial collaborative agreement.
So when there's Kelly, if I may ask, if there's a group of physicians and the patient is before you, the patient should know who their physician is, right? And they should be then telling you, my physician is John Smith, whatever, and they should be on that list. The collaborative practice agreement contract, right? It should be listed in there.
So if it was a situation, a lot of times these are done through referral. So the physician is referring patients, make an appointment with the clinical pharmacist. In the case a patient would just show up, I guess this could happen more like in a community practice setting. Yeah, that agreement would have to be in place with that physician clinic or that physician office. That right now, we don't have the ability through the law to do like an open collaborative practice to where a physician that didn't already have an existing relationship or an agreement to sign one of these orders. So that pharmacist would have to have an agreement in place with that provider's office, not necessarily with that provider themselves, but with that office where they would have had to initiate care originally before that pharmacist could see them under that agreement. Did that make sense? I'm not sure if I answered your question.
Yeah, it makes sense to me, Kelly. So what I'm hearing you say is, as long as the patient is an established patient of that provider's office could have one provider, could have 50 providers, we'll say. And as long as they have a contract with that pharmacist, pharmacy, what have you, as long as they're a patient of that provider, that they would be covered under that agreement, as long as that was in the scope of that agreement.
Correct.
So we need to craft language that prohibits or allows that.
I think that'd be up to the committee, because we try to make the statutes pretty specific so that we don't have to add, a lot of additional rules. So hopefully, I guess depending on what it was, if we felt something needed to be clarified, I just want to make sure that we're sticking to the original legislative intent of the bill and not kind of deviating or doing something different than what was originally agreed upon between our organizations and the physician groups that we were working with. Because a lot of these agreements have already been in place and have been in place since early 2000s. And so I just don't want to create a situation where now you have workflow issues or agreements having to be redrawn up due to unintended consequences.
I'll throw it out to the task force. Do you think we really need a rule, or do we think we just need an FAQ?
Well, in the collaborative practice agreement, the definition says an agreement between a pharmacist and a provider. Can we add or provider group?
Are you looking at the law book on our website or?
That's
Yeah.
changed.
Yeah, that has changed. It's modified. So if you look at the Secretary of State's, it is kind of group to group, individual or group to group. It's broad.
Yeah, my personal opinion is I don't necessarily think we need another rule. Maybe there's an FAQ. I mean, I don't want to be so specific in the FAQ, though, to Kelly's point, that we limit practices that have already been in place that have been happening maybe for years very safely in the state.
Well, the FAQ can pertain to questions we're receiving at the board office, and then just add to the list, and that may help further clarify and address some concerns or questions out there.
I think one of the questions that we get frequently there's conflicting information, at least in the past, that has been given out, is regarding to like practice setting that pharmacists there's no restrictions to practice setting. So you can be in any practice setting as a pharmacist. You don't have to be in a licensed pharmacy. And that's been, I know, a confusion between some people in the past where they thought they had to be in a pharmacy or in a licensed pharmacy to be operating under these. And that's not the legal intent of the statute. And that was clarified back in 2011. And then we made further clarifications to the definition of a pharmacy to make sure that pharmacists that were working in physician clinics or AMPEC clinics had under these agreements didn't have to, or telehealth type of things didn't have to be in a licensed pharmacy. They were regulated under their pharmacist license.
Sandy, I know this came up in our discussion yesterday with our compliance team. Were there any other concerns, questions that you guys are facing?
The questions that we have been getting recently, we have had orders initiated by pharmacists that have gone outside of the practice setting in which all of the practitioners and pharmacists know what the collaborative practice agreement is. So for instance, they'll just take it to a retail pharmacy rather than the clinic pharmacy, et cetera. And that has caused some questions and concerns because those prescriptions are not being filled at those pharmacies because they have no knowledge of the collaborative practice agreement or the practitioners and pharmacists involved and what that agreement actually states. So we've had, in fact, I think we have one or two complaints that have come in regards to that specifically.
Is there a way that we can clarify that in an FAQ? Because there's nothing legally wrong with that. I can see the confusion though if you're in a pharmacy, but there's no legal requirement for them to verify or see the agreement or verify the agreement. But is there, and I don't know what the solution is to that bit, but we could potentially see more and more if patients are allowed to leave with those prescriptions. It'd be no different than like a PA on there. They're working under that delegated agreement and they are technically allowed to prescribe as long as that physician under that CPA is given that authority. There's no restriction to get it filled in the clinic.
Sandy, let me clarify what you're saying. So if I'm hearing you correctly, the complaint is coming from another pharmacy feeling like the pharmacist that wrote the prescription under the collaborative practice agreement was doing so outside of their authority because they were not aware of the agreement. Is that what you're saying?
It could be that, or it could be the pharmacist involved in the collaborative practice agreement not having orders that are filled. The concern is that, a pharmacist outside the setting, they do have an obligation to make sure that they have a valid prescription. And without the knowledge of what that pharmacist within the collaborative practice agreement can do, there's no way for them to look it up because those collaborative practice agreements and those pharmacists that are involved, there's no reporting to the board. There's no method to actually assess what their collaborative practice agreement is outlining that they can do under that agreement.
I don't think any state has a process where pharmacists, I mean, because there's collaborative practice laws that are on the books and have been on the books, like in Washington State, for example, since the 70s. And they're prescribing regularly under those. Billing for service is actually under the medical plan. And they're not, to my knowledge, there's no requirement that they see those agreements or know what those agreements say, or any onus on the filling pharmacist, pharmacy. And maybe Lori could speak to that, because I know she works with other states, but I'm not aware of any state that this is, that they've had rules or any requirements on that.
Yeah, I agree with you, Kelly. There's some states that require submission of the collaborative practice agreements. There's a handful of states that require approvals of collaborative practice agreements before they're used, but I don't see how that would solve the issue that Sandy's talking about, because it's not like it's posted that says Kelly Fine can write prescriptions under Dr. Smith, something like that, and this is the scope of that. It's not like you can validate that on the board's website or something like that. I don't know of any state that keeps a repository to that degree.
Don't we have this issue anyway with pharmacists getting prescriptions from out of state, and they don't know whether it's a collaborative practice agreement or a nurse practitioner, or a PA, or a psychologist from New Mexico? They have an obligation to fill a valid script, but however they conclude that is up to them. I mean, we have this in lots of scenarios now.
We do, and it'll probably be a professional judgment decision they have to make. Is just if we can clear the air within our own state to mitigate, hey, I can't fill this because I can't validate it concept, might help patients at the end of the day, because they won't get turned away.
An FAQ on the board's website about collaborative practice might be helpful here, that you're going to be seeing more of them, and that pharmacists do have that authority. But you still have the professional judgment to verify, like any other script.
Yeah, I agree with Roger that this doesn't need to be legislated as much, communicated.
And maybe that's some guidance that we could send out to the facilities that are using these regularly, or maybe have more examples of people that might be taking prescriptions elsewhere. Like maybe there's a cover letter or something a patient could bring to the pharmacy saying this is in accordance with, you know, XYZ facilities, collaborative practice agreements. If there was a phone number or something to maybe clarify it. I think as people get more familiar with the clinics in their area, I think some of it will resolve itself, but I haven't heard of any other state. And there's a number of states that have collaborative practice. Almost every state has some variation of a collaborative practice law where that's come up in the discussions of needing to see that agreement or knowing what they can do and not do. That's not the onus of the dispensing pharmacy, other than, you know, within the parameters of law, making sure as best they can to make sure it's a legitimate prescription and safe for the patient and all of that.
So what I'm hearing is maybe we can get our questions together. Kelly, maybe you and I and Sandy and Jennifer can sit down and answer it to the best of our abilities. And at least clear up the air a little bit. Obviously, it's just creating some concern out there. I think concern in the back of my head is I hope insurance carriers don't start auditing and saying, hey, how did you validate that this prescription was under a collaborative practice? And take back unnecessary money that the patient benefited at the end of the day, but the pharmacy got penalized for it. So sooner we get something out there, I think it'll help protect the pharmacist's pharmacy and then ultimately serve the patient's needs.
To that point, Cam, are there any parallels that can be drawn, as Roger was bringing up, from other practices that are in place with nurse practitioners or PAs or out of state that prevent insurers from doing the clawbacks and protecting the pharmacies and the pharmacists?
That's always on the radar, and that's a risk every time they fill a prescription. That's a risk that they're taking. I think the overall thing is, in many states, nurse practitioners have the authority to prescribe. Physicians' assistants have the authority to prescribe under a supervision. Collaborative practice is continuing to expand more and more. It's been in some states, but it's coming up more. It's more active now than it's ever been before. So maybe that's what's causing the angst a little bit, but we'll try to work with those questions and try to get those on our website as soon as possible.
To that point, I think Matt raises a good point. The aggressiveness of the PBMs for technical violations of their provider manual are frequent, and the more data that a pharmacy can provide to a PBM auditor, this is considered a legal order in the state of Arizona, the better.
Any other discussion on CPA?
Does that mean that like potentially in whatever guidance we put out, that it should be really explicit that there is not a requirement to validate a CPA exists on all these prescriptions? Instead, you should just be using your professional judgment?
I think that's worthy of stating, yes.
Cool.
And I think the other concern, Sandy, is about prescriptions moving out of state. And I think we probably have to, it would be up to the other state, the pharmacist in the other state to do their due diligence, just like I think we do in this state. I mean, we have mid-level pharmacists practicing in other states. They have more than a collaborative practice. They have prescriptive authority in many states, and they're allowed to cross into our state, and our pharmacists are exercising their professional judgment when they fill them. So I think they would have to in turn do the same in other states.
I agree, and I think we're seeing more and more prescriptions coming in, particularly from California lately, and they do have I forget what it's called, but they have a designation for their collaborative practice pharmacists.
Anything else on that subject? All right, we'll start working on that. The next topic on my agenda.
Michelle, we've got some
Sorry.
background there.
I'm sorry.
Oh, sorry. I threw it into mute category. Second subject or third subject is not dispensing pharmacies. I know this is a discussion that we've had with the board. There are entities that have facilities that just provide MTM services, drug utilization services, or some sort of cognitive function in processing prescriptions or providing pharmacy care without storing drugs on that facility. And we were to carve out some rules because not all the rules are required for instance, security parameters, because this is all computer-based, cloud-based technologies that they're using. Any thoughts on how to proceed with that?
I would suggest that we look at Idaho. Idaho has theirs split into two sections, pharmacies that have drugs and pharmacies that don't have drugs. Their rules are pretty streamlined, easy to follow, not a lot of detail, but that's my suggestion of maybe perhaps where we look to start.
I also want to make sure we're careful on how we designate, like, because I thought we had the limited service pharmacy license already, but we had already made a statute change based on recommendations from the Board of Pharmacy on the definition of a pharmacy, because we were having issues with pharmacists, in collaborative practice agreements or working on a telehealth team outside of a pharmacy, being told that they have to now be in a permitted pharmacy if they're doing cognitive services. And we specifically ran a bill to carve that out that didn't require a license. So I want to be clear, and maybe there's examples of situations where a license or rules might be necessary, but practice is evolving as well. And so there are a lot of examples of pharmacists out there providing clinical services, MTM, using cloud software and things that aren't necessarily, they're not housing data in their homes or anything. But I don't want to, I guess, go back in time and recreate something that we work to remove because of the evolving practice of pharmacists not necessarily needing to work in a pharmacy.
Yeah, I hear that for sure. I think that Sandy had requested this one because there's like no way to inspect a non-dispensing pharmacy like right now within the current rules and framework, because they like don't need as many things as like the other pharmacies do. I do think like because some there's some requirements that like will require a pharmacy license even if you're not handling drugs, so like PBM contracts or whatever. So I think that like this kind of appeases that need. But yeah, I do want to be cognizant of the fact that like we shouldn't be requiring a pharmacy license for these things too. It's like more maybe like an option. To add on to the Idaho comment, they do a really nice job of like being kind of like permit type agnostic, where they inspect based on what you do, not based on like what type of permit you have. So I think that is something that I'm super interested in, as opposed to having to be like totally locked into like one type of permit set, if that makes sense. Like for instance, if a retail pharmacy delivers drugs, that doesn't make them a mail order pharmacy. You should just like go ahead and check that they're following like some sort of things related to delivery as well as their usual other business.
So can someone explain to me, we've had non-dispensing pharmacies in Arizona for more than 20 years. They're usually come in as a limited service pharmacy and they ask for a variance as to certain things they don't need. They don't need mortars and pestles, as an example. What's wrong with what's wrong with this system, and what are we trying to fix?
They were just trying to get away from the deviation process, Roger, so that we can vet it behind the scenes. If everything checks out, issued a permit without inconveniencing them to appear before the board and all that good stuff.
Can we just change it so that we give the authority to the director and staff on a limited service to allow deviations from that? I mean, isn't that where we're going on some of these space issues anyway? I'm just thinking out loud.
It's a good suggestion, Roger.
I mean, if they were to delegate the authority to me, I think everything that's delegated to me today, most of it is through statutory authority. So we might have to create some sort of avenue to give me that authority to do.
But I mean, the inspections, I said we've had some, I think they're more than 20 years. They've been inspected every year, every 2 years, for years and years. They still have to have adequate security for what they're doing.
Yep.
Appropriate licenses, policies and procedures, all that stuff. I mean, we can write down a set of rules. I'm just not sure what it does.
I think there are a couple things to consider, and I don't know that the system is broke enough to try to fix it, but there are two policy issues. One is the limited service pharmacy permit does not describe to the public that this entity does not possess or distribute prescription medications or devices. And so presumably someone could attest to the board, I'm never going to do that. I'm just going to provide cognitive services. But McKesson, Cardinal, Bergen, the other wholesalers wouldn't know that if they ever tried to order a drug. And so I think there's some benefit in identifying, at least to that constituency, hey, this thing has attested to us that they're not dispensing and won't possess anything inside their walls. And to that end, the one thing that has always bothered me about someone who has worked with a number of non-dispensing pharmacies are the security rules. That is there has to be a solid barrier that goes all the way to the roof deck. And if all you have inside the place are desks and computers that are password protected and don't store anything on the hard drive, everything's on, you know, a web-based server. I always thought that was something silly and antiquated from the days that every pharmacy had something in it that was worth stealing. And many of these dispensing pharmacies just don't need that level of security. So those are the two things I can think of that might be worth discussing fixing, but I don't know if it's a big enough problem to try to fix regulatorily. I'm a big fan of less rules and not more rules, but those are the two things to consider in my mind.
Didn't we tackle the security issue in our last meeting, though? We simplified it quite a bit, just what was needed to protect the records and appropriate access. Kind of distilled it down.
I was at the last meeting, and if I missed it, I'm sorry, but I don't know if we talked about the whole barrier that goes to the roof deck. That's the one silly thing that doesn't make sense in a lot of these places.
I do think we talked about that.
Yeah, it was taken out. It just
Okay.
said,
Then great, that problem solved. Check it.
Yeah.
Check it off the list. Thank you. Sorry.
Did we distinguish though the requirements between a dispensing pharmacy and a non-dispensing?
no,
Like Mark was saying, I remember talking about that, but I thought it was more in the context of like the regular pharmacy permits.
Yeah, we did touch on the subject. I think we determined that it could fall under limited service and we could expand that rules section to incorporate non-dispensing pharmacies. But to Roger's point, if we just, I guess, put in a bill next year allowing me to just approve that deviation, that might solve the issue. So we don't waste anybody's time.
Do we think that like we could do this, like kind of like serve the same purpose though in a rule set by like not requiring a mortar and pestle if you don't compound or something?
I think we talked about that too.
we did.
Okay, sorry, I wasn't here at the last one. And I apologize for that.
Yeah, I think we did simplify that as well. Equipment.
Yeah, I think it was, yeah, you need the references needed to perform the services you provide, need the equipment needed for the services you provide and so forth. So
Awesome.
Is there a way to pull up the rules for limited service to see? Because maybe to Emily's point, maybe there is a way to address it more in the rules as far as what's required, what's not. To where it wouldn't, and I thought there was a statute, Cam, that said that the board could delegate. They just had to they had to approve the task delegated and that list had to be available or posted on the website or something to that effect. I didn't think you had to pass a bill each time the board delegated an administrative task. I didn't think.
let me pull it up, see if I can find that.
So could that be a blanket statement or is that just per licensee or permittee?
So outside of this delegating authority, was there another one you thought was in there, Kelly?
I was on mute, sorry. I thought there was another statute on the books, but I could be mistaken. Because I think this is specific for like disciplinary action.
Yeah.
I thought it was like in the.
But if we're changing security, and equipment to adequate for the operations that you have, I'm paraphrasing and simplifying what we did last meeting, what is a limited service pharmacy going to need as a deviation? Or not a limited, non-dispensing.
It might be helpful to like look at the inspection checklist or something and see if there's just certain things that are
I
coming
mean,
up.
most of them end up not applicable, but
Yeah.
they're not a problem, yeah.
Agreed.
So we may have already solved for it.
Well, I'm just trying to figure out what problem we're actually solving for, other than, I don't want to waste board's time, but if we're already making the changes on equipment and security as to adequate for the practices you have.
Up until now, all of those non-dispensing sites have been held to the same square footage, security requirements, equipment requirements as all of the limited service, because we didn't have anything else to go forward with. So after the changes that have already been made about the last thing that might be still out there is what Mark said about providing notification for the wholesalers that this is a business that can't order and possess drugs or devices.
I guess that's useful. Have we ever had that as an issue?
The wholesalers come out when you're getting a license, don't they? At least the major ones, they like basically kind of do their own inspection based on my experience.
Yeah, and I believe they interview like the pick and
Yeah.
a bunch of different things.
So in this section, it does say, this is what we reworded it to: the pharmacy permit shall provide reasonable security based on permittee's business model to ensure drugs, devices, and records are secure. Do we need to change the header?
Can it just be pharmacies?
It would be hospital pharmacies and pharmacies, and this is more based for community / chain pharmacy stores.
Perhaps you want to look at the intro to the limited service section instead. That would be section 671, the general requirements for a limited service pharmacy.
In the definition section, it looks like we modified the community pharmacy definition to say a community pharmacy does not include a hospital pharmacy or a limited service pharmacy. Well, I don't know if we made that change. I can't tell. It's highlighted on in the packet.
Thoughts on putting maybe just something in here?
We just put that statement that was in the community pharmacy section that just says we'll have applicable or necessary security or whatever based on the needs of, or based on the business,
Yeah, that's a good
however
suggestion,
that's
Kelly.
worded. Because it really would depend on what they're doing and how their systems are set up.
Right, if they have paper records, they would need to have probably additional security versus having something that was not, only computerized.
Appropriate security and applicable equipment.
Yeah.
Okay, I'll wordsmith that. Okay. Anything else on that, guys? And that may already address, well, we got the next section, section 4D is infusion pharmacy. And we have two types of infusion pharmacy, inpatient type environment and an outpatient type environment. And I don't know if our sections address it. Our limited service obviously is pretty broad on what services I guess they can provide. We can maybe incorporate something in there as well. Right now, I can tell you guys that infusion pharmacies and compounding outside of a pharmacy by nurses, nurse practitioners, MA, and all that is becoming a hot topic and unregulated by a lot of, there's no oversight going on today. Becoming a bigger issue, not just in our state, but across the country.
So what are you hoping to express in the rules?
I think Bina, you and I talked about this a little bit. What are you seeing out there?
So it's a lot, right? So it's it includes ambulatory surgery centers, physician-based practices, as well as organization that actually have that own physician-based practices. And we're seeing a lot more for maybe oncology and some of the infusions that are being administered outpatient. And this is just so that patients can access care close to home. So they're all over the valley in Arizona, and I know other states as well. So the issue we face with these kind of practices is that we can't have a hospital pharmacy license because from a DHS perspective, these are not hospital DHS licenses. And then we can't use, we have to always do a deviation if we're using a limited service pharmacy because the current rules related to limited service, they require it's more outpatient focused, like retail. They require like an outpatient label, outpatient prescription. They don't allow for automated dispensing machines. A lot of these infusion sites, it's more like the patients come in outpatient, but they're more aligned with the hospital-based practice. So the physician orders it through an EMR, just like a hospital. I'm just going to give an example of a chemo medication, and then a pharmacy tech prepares it in the sterile environment, and then a label is generated, but the label is more for the nurse to administer, right, instead of the patient to acknowledge and self-administer. And then readily available, making the pre-medications and things like that readily available to the nurse that's in the infusion clinic to remove them from the ADM after the pharmacist has reviewed the order, and administer it to the patient. So while, they could be in the chair for a couple hours, depending on the infusion, but they may get nausea or something. So they want a quick access to a nausea medication that's already ordered as a PRN basis. So what I'm trying to say is we may need to include some of the hospital-based practices somehow into the limited service license. Or I don't know if this is possible to have just a separate section for infusion clinics. The other issue is, some of these are so rural, we can't really always staff those with pharmacists. But we do need pharmacist oversight with the cognitive, reviewing the order, making sure it's appropriate. Renally, like physicians order, but somebody has to review that order, and these are high-risk medications. So how can we still provide some cognitive services where a pharmacist can review the orders for the physician for these remote sites? And I don't know if I know we did have a section now for remote hospital sites. Would it be possible to have a remote limited service sites? Again, very new to this, so please let me know what we can do here. It's really growing, like Cam discussed, and it's all over. I think Dignity, a lot of the major hospital systems, along with Honor Health, are facing these challenges right now.
I think the other issue that Cam brought up too, and I don't know if this could even be addressed, is it's one thing if you're involving pharmacy and pharmacists, but there's a lot of centers out there and clinics that don't utilize pharmacists because of all of the regulation and the potentially cost. They don't even employ pharmacists to oversee the compounding, the dispensing of these products. They may hire technicians or others to compound and do that, but it's like they have a different mechanism for approving those medications and all of that. And so that's kind of outside of this realm too. So I think while I don't necessarily think that's a good model and a safe model for patients, if the rules are strict or we don't factor in everything, as Bina was saying, are we going to direct even more clinics and sites to opt and not want to utilize pharmacy services for these types of services? Right. Because it's too onerous. And so what's the balance between, the patient safety aspect to make it so that it's not too restrictive or allows for the things that Bina was talking about with labeling and things that need to be considered, but also how do we address the other component? And there's a lot of clinics out there that specifically carve out pharmacy intentionally and are utilizing other individuals, I guess, to provide services that typically have been under the pharmacy umbrella.
I can tell you that we may have stirred the hornet's nest by having a discussion with DHS, the nursing board, medical board, and I guess tapping them on the shoulder to see who's got the authority over this type of compounding. My concern is, since there are prescription drugs involved, and if something goes wrong, the first place they're going to point pictures to is the Board of Pharmacy, because that's where pharmaceuticals are typically regulated. So that's why we kind of tap them on the shoulder to see what's going on. Now, I know the physicians have compounding authority through the federal language. It's not, I don't believe it's stated in their statutes and rules. And if it's not stated there, are they able to delegate this authority to their subordinates, hiring a technician and calling them an admixture tech or an MA to do these services? Don't know yet. That's up in the air. We did throw that out there for discussion, but we haven't gotten an answer back. But it's definitely being talked about. It's something that we probably need to address as well. It's something huge to chew on today, but I think it's good food for thought for discussion going forward.
Since I'm not familiar with like this practice very closely, is what I'm hearing that almost all of these components and steps are basically already allowed in different areas of the pharmacy code, like for different practice settings. And the issue is that we're just not permitting these things in these types of clinics specifically, like as a permit type or something like that. Because all of these things sounded very normal, like pharmacy type services.
So here's a problem with a lot of these infusion centers and surgery centers that provide oncology services are outpatient based. And so we have an outpatient pharmacy, but outpatient pharmacy requires a prescription, not a prescription order, right? So, and you don't have visibility into charts or anything of that nature. Whereas a hospital, remote hospital pharmacy is tethered to a main hospital that's licensed under DHS. So even though the service can be provided, it doesn't cross over, right? Some of what we can do in a hospital environment needs to be able to be done in the outpatient pharmacy environment, and we have parsed those two out into two different buckets. So somehow we got to create this Venn diagram that overlaps it a little bit so that we can then connect the dots between the two services. Did I explain that right, Bina?
Yeah. And, I think that's a key. They're like outpatient surgery center. It's like this kind of like a building where the patients come in just for the infusion for the day. And so they're still considered outpatient. So right now we don't have an option to make it a hospital pharmacy because it's not a hospital pharmacy license permit.
Right.
And we can't call it a retail because it's not retail. We have a venue to use a limited service, which some of the hospitals are using, but then we have to always put in a deviation, or we need an automated dispensing machine. We need a labeling, just like a hospital labeling. So I don't know, maybe to start off with, we put some language in the limited service pharmacy, because that does allow for sterile compounding, right? And kind of just say in an infusion center or something practice or office-based practice, labeling requirements will kind of refer to the hospital requirements, and kind of not always look for the retail. And Sandy can speak to this as well, right? Because when Sandy's, when they're looking at it, they're asking for a log, a prescription log, because we're not handing the meds to the patient, we're handing it to a nurse to administer under the physician's order. So it's kind of like a mixture between hospital and not even retail. It's not even a retail, it's just a hospital in an outpatient based clinic.
Yeah, a lot of these are extensions of the hospital itself. And so it may purport to look like a hospital, act like a hospital, follow CMS, their inpatient and outpatient prospective payment system. And in order to receive the elevated payment profiles that they do, they have to meet certain requirements of an ambulatory outpatient setting. So they are representing all things hospital. It's just they are not part of the four walls of the hospital, but they act like a hospital. They have hospital coverage if something goes wrong. For patient safety, they have to meet all of the constituent parts of a hospital. They're just called an outpatient hospital. So CMS addresses this in their outpatient PPS, and everything is stipulated what they have to do in order to receive the higher payments or the payments that are wrapped around CMS. What I think Bina and others are talking about is making sure that all of the criteria of patient safety for our community, for the members that go into these places to receive care, are, as CMS and others have kind of outlined, that they have to meet in order to provide patient care. It's just not simply the billing component, it's also the quality, safety criteria that have to be met. And no, it doesn't really meet a retail, it doesn't really meet a hospital, but it's much more similar to a hospital. It's just in a different building.
And then there's a whole other subset of people that don't have any pharmacy permit that are doing infusions and providing these services. That's kind of the unknown area right now, where they're not required by law to have a permit to do it, or a pharmacy permit, I guess, to provide those services. So some clinics don't have one.
And Kelly, would that be just would that be like a doctor's office that is doing infusions under the supervision of a physician?
Yeah, it could be. Yeah, it could be any. Yeah, clinics. I know that there's oncology clinics out there that don't have outpatient pharmacies in-house, but they provide, you know, they compound medications there and dispense medications essentially. So I'm not sure how that filters in, and I don't know how other states have addressed it, but
And every med spa and IV hydration place that is on every single corner is doing this.
Yep, and they have no oversight. DHS doesn't license them. We have no oversight. Nurses may be there. They may not be. We don't know who's in those facilities. So that's a big blind spot. But to address the immediate concern of hospitals, and again, being you're the expert, Matt, you're the expert. So there is an umbrella under the DHS, but these clinics or remote locations are designated as OPT, right, according to DHS.
Yes, yeah. The
So
outpatient facilities of the hospital, some of them are, yeah.
So then if we carve out saying the main hospital license under DHS with remote locations operating as OPT can operate under hospital type statutes and rules, that may solve the problem.
Are you trying to gain oversight over some of these other clinics that don't currently have oversight? Or I guess I'm not entirely understanding the problem.
Yeah, so I think we're trying to, we are trying to have pharmacy oversight at some of these clinics. And, you know, they are under the supervision of the physician, right? And they are administering oncology medications, infusions to their patients, but there's no oversight from pharmacy. And we can't provide those services under, you know, some of the licenses that we currently have. So we're just trying to figure out like the best way to make sure the patients are safe, right? Bottom line, and that somebody in pharmacy, pharmacist and a pharmacy technician is helping or assisting the physician-based offices.
And we don't have a
Lori, I
permit.
think,
We don't have a permit type today that fits that.
yeah. And I think, Lori, that's exactly the point that has caused some confusion. There really isn't a permit type to adequately explain what goes on there, because these buildings are doing everything that a hospital does.
Mhm.
And so they should be, you know, from chain of custody to where the medications are stored and how the medications are stored and how the medications are dispensed and how they're compounded. All of that is very much a hospital-esque setting, but they don't fit in the four walls of the hospital. So there's confusion of, well, do they still need the standards of practice? Do they still need the USP guidance? Do they still need pharmacist oversight? Do they still need director of pharmacy to control these? Are all those stipulations, regulations still in place because they're not actually in the four walls, but they're doing everything a hospital, mostly everything a hospital does. So without that license, it's made it a difficult conversation.
So do we need to look at creating like a physician dispensing type of license? I know there's a handful of states that have those.
Yeah, it's not a physician dispensing, because a lot of these into the different health systems, it's the health system acting as the health system. It's not a physician acting as a physician. They're just, instead of practicing in this building, they're doing everything hospital in this building.
So it's a remote hospital operating as like an outpatient, but having access to the patient's charts, medical records and all that good stuff. And still deem it as kind of like a remote hospital site pharmacy,
Mhm.
operating in an
And-
outpatient environment.
And do those environments, because they're very similar to a hospital, do they still need a pharmacist to review the orders? Do they still require a pharmacist to be involved in the dispensing? Does a pharmacist need to be involved in the chain of custody? Those are the questions that have had a hard time being answered to this point.
I think like along the lines of, I think this is part of what Lori is asking, is by creating some type of like permit type that encapsulates these, this is intended to actually like permit this practice as an extension of the hospital with pharmacists involved, right? This does not address the types of physician or like IV centers that are like in mini malls, right? Like this does not touch that issue. It just allows for the pharmacy type
Correct.
services to.
That's correct.
done.
The other that you're describing, Emily, is a lot bigger
Yeah, okay,
challenge today.
helpful.
And this is Mark as a non-hospital constituent. I'm a big fan of this. I was able to tour a hospital system, and the pharmacy facilities are very impressive. The remote site facilities that are part of the hospital system that are owned by that hospital, and those patients are treated at that hospital, those compounding areas and the patients are getting anti-neoplastics are not impressive. And the fact that the pharmacists aren't able to provide more support because there is no license that can be issued, the remote hospital license, is discouraging. I think this is a big gap that can be easily solved with this kind of license type. I said earlier, I don't like new rules, but this one is one that I think would benefit the community, benefit the hospitals, benefit the hospital pharmacists. When I talk to the pharmacy directors at these health systems, they're like, we would love this. We want to have reasonable oversight, even if it's closed caption television, to help these remote sites, because we know those people don't have the same training as we do.
And I think the remote hospital site it's a great venue, but I think these infusion centers are so complex. So the remote hospital site license that the board just recently approved helps with more like the freestanding EDs, right? Because it's just more like an extension of the hospital. But these infusion clinics are more complex. There's, these are like high risk patients that are being treated there. So we just need something more clear cut to help have some pharmacy oversight there.
Can we modify that statute, Bina, Matt, to incorporate OPT in the practices that occur there, so we don't have to start from scratch on anything else?
Cam, can you say that a different way?
So we have a remote hospital site designation today that we put into play a year and a half ago or so, which allows for emergency departments as an extension of the main hospital to have a mini pharmacy operated by a technician. Can we alter that language slightly to incorporate outpatient infusion?
We can, and we'll have to also resolve the PIC situation, right? So a lot of times, I think the way the language is written right now, the main hospital PIC is responsible for all these clinics, and we could have tons of, different. So how does that one PIC responsible for these? Unless we can have an opportunity to have a PIC at each of the sites, or maybe 2 or 3 sites, but not keep it on the main supervising pharmacy. I think that's the issue that we're facing currently.
So
Cam, I don't know if the. Go ahead, Roger.
I apologize because I don't know enough about these. How do the drugs get to these sites? Who buys them?
So they are purchased under the physician license, and a lot of these are office-based. They're actually ordered. They are hiring pharmacy technicians to order these medications for them, and then between the nurses and the pharmacy or the mixing techs, they get the meds, they mix them.
But they're ordered under the individual MD's personal license.
Yes.
And I would say that I think some of them are ordered under the hospitals. From my experience, some of the hospitals order these and they just do a ship to, bill to transfer.
Right.
Because it seems like the remote hospital thing, we tried to do that. We tried to solve for the issue with the DEA registration on this. And it seems like this fits the same thing. It may just be tinkering with some of that language.
Yeah, it may fit more closely with the hospital license than it does the remote one where the tech is hired to run the ED. I think maybe we need to take a look at that and then we can make a recommendation, Cam.
So is it okay with the task force that I work with Matt and Bina to see if we can put something together?
Yeah, I think they have the most experience here.
Right, I'll work with them.
Mostly Bina.
No. I mean, we can work. Matt has some experience with this too. So yeah, I mean, that would be very helpful. And thank you for the, for the opportunity to work on that.
I'm gonna share my screen and we'll pick up where we left off last time. If we can get into the rules package here. Everybody able to see my screen? Make it larger, smaller?
Fine.
Right, so we left off at R423 651 definitions. It looks like there been some removal already of definitions, and if that makes sense to you guys.
What do we use direct copy for? And is there such a thing as a carbonized copy anymore?
Once the DEA took the carbons out of the 222s, I think they were the last carbon copies that existed.
I just don't
Um,
remember where it's used.
Yeah,
It's,
direct copy is in 654 as well.
Yep.
658. And one other section, 672.
So about correctional and hospital pharmacies attaching some sort of order or a copy of the order,
Right.
storing it.
Does it need to be defined though? Sounds like that's a typical definition of copy.
Yeah, is there like some sort of special thing about like some sort of special type of copy that needs to be made? I don't understand.
Direct copy. You can't have a copy.
Yeah, you can't do a copy of a copy.
Is this like at the UPS store, like a certified copy or something? I don't think anybody's gonna do this.
Yeah, it seems like it should be stricken.
All right. Stricken it is. And then anywhere that says direct copy, maybe just move it to copy of a physician's written order. All right. Any other questions? Okay, scrolling down. I know, Laura, you had mentioned that this should probably stay in. I think we have supervision defined in an earlier portion as well. We need to continue to define it.
Thoughts from the group on that?
I don't know what is it called? Just hospital pharmacy. If we keep it, I think we should add electronically or something if we're going to define it.
I mean, compared to direct supervision, there is a distinction slightly. And either we can expand that definition or maybe keep this one.
Don't we already have supervision defined in 101? Or the very beginning of this, whatever the number is? 10 to 110.
In a second here, Roger.
Yeah, there's a definition of supervision at 110 in 110. So I'm not crazy about having the same word defined differently twice, which we already have.
I agree.
Okay, so we'll have it removed.
I think so.
Now, guys, I know this was short notice, but as I was reviewing the rules package to go over with you, I noticed several sections were not in our original packet, so I carved them in. If you're not ready, we can always discuss this at a future time. You can see the fonts and formatting changed a little bit for the sections that were overlooked for a complete package. So it's up to you guys. We can move past it and then readdress it in the next meeting or try to work through it.
I'm wondering if we should go back to some of the things we'd started to talk about. For example, we talked about pharmacy technicians taking refusal counseling. And we just kind of said, oh, yep, we'll bring that up at the next meeting. I also wanted to talk about water, hot water. I know we discussed it a little bit. And it was said that it was a USP requirement to have hot water. I found cleansing with warm water and sterile water versus potable water in USP. I looked at other states, it just said sink with running water in Florida, I have different things, comparisons. So I don't have a problem with hot water and if we say what hot water means. Because I don't think someone should be dinged on it because it didn't feel that hot to that particular compliance officer.
Thoughts, guys, anyway?
I think the benefit here is for personal hygiene and washing hands, and also washing dishes. For pharmacies that are dispensing, those activities are important. And I'm happy to work with you, Cam, on if there's a more specific definition of what degree is hot for purposes of washing dishes and hands. I express this frustration as someone who's practiced and still does occasionally for over 30 years and going to a place where there is no hot water to wash my hands or to wash the dishes is very frustrating.
I've also read, though, from CDC that to be able to effectively have hot enough water to kill the germs, it would be too hot for us to touch. So it's the soap that's really the thing that's killing the bacteria versus the heat of the water.
So you're saying my mom was wrong?
Yeah.
Okay, fair enough.
Yeah.
I don't know.
Like typically, it doesn't really match up with what we typically say hot water is best, but hot enough is the question. It's just so arbitrary of what hot means.
Well, even if I absolutely believe you, and I trust that's true for the killing of the germs. But I do know that when washing dishes, particularly mortars and pestles, it is really, really hard to wash a mortar and pestle without hot enough water to melt the glycerin or some of those things. And so
I agree.
I would still be frustrated.
So then should we define what hot means?
Yeah, and I don't have that answer off the top of my head right now, but I'm happy to do a little research and work with Cam on a reputable source that is pharmacy related that makes sense.
I think Wikipedia probably defines it, Mark.
I'll find that Wikipedia right now.
All right, Kristen, you said you wanted to address the counseling component.
Yeah, actually Lori brought this up, but I think it's worth a discussion of possibly.
Yeah, I think I sent you draft language, didn't I, Kim? A while ago after that last committee meeting. Or maybe I'm making that up in my head.
All right, so we're in a counseling section here, and I'm looking for your email as well, Lori, if I can find it.
I'm looking forward to Kim. Can't find it. Maybe I didn't send it to you. Kristen, did you have a suggestion?
I don't know how it's worded. I just know that you brought up the topic, and I think it's an interesting idea that I can speak from personal experience. You just have to hold someone's medication hostage, and it's just like a really awkward, unpleasant experience when many times someone does not want to counsel, so they're being held hostage. Just tell the pharmacist they don't want to counsel. So I would be in favor of pharmacy technicians being able to accept the denial.
Yeah, I've always thought this was interesting because if somebody says that they don't want to be counseled, I guess I'm not sure what the pharmacist is expected to then like add to that scenario when someone already wants to leave.
Mhm.
Especially taking them away from their focus to talk to somebody who doesn't want to be spoken to seems a bit like counterintuitive for their focus when checking prescriptions or doing other clinical work.
you may want to look at Rule 1104 with the delegation information that was added the most recently, if that's where you would like to put it, because right now a pharmacist can't delegate counseling a patient or anything that would require an exercise of professional judgment. So you could take a look at that particular section and revise if that's something that you wanted to do.
That was the section I actually had a question about as well. I don't think this would be clinical judgment. So, and they wouldn't be counseling, so I don't know that the language here would need to change.
Kristen, what's the scenario that you're envisioning with the technician here?
The patient has had their levothyroxine change from 50 to 75 micrograms, and they've already talked to their physician about it. They come into the pharmacy and they're picking up their new dose, and they say, oh no, I've already talked to the physician. I don't need to talk to the pharmacist. I've been taking levothyroxine for a long time.
So they were asked, do you want to talk to the pharmacist?
I think what she might be explaining is when they say like, oh, this is a new prescription, or the pharmacist says this needs counseling, like, please hold. And they have to go get the pharmacist. That's when the person would say, I refuse.
I don't want to, yeah.
Because I see frequently the piece that I'm raising is, do you want to talk to the pharmacist? And my fear is that's going to be turned into a refusal to counsel.
Well, they're not supposed to be asking that now. I would typically say the pharmacist wanted to talk to you because this is a new prescription. And then people would say, no, it's not new for me. It's just a change in dose. I'm not interested in talking to the pharmacist.
My concern is, I think that the mandatory counseling is not followed most of the time in Arizona today. And I don't want to encourage it more because I still think it's the single best point where we can catch errors.
I don't disagree. I just think it's a little bit of a strange exercise to like hold people's medication hostage that don't want to talk to the pharmacist.
And I don't disagree, Roger. I agree that this is the single most important thing that we can do to prevent errors wholeheartedly. But the reality of it is the documentation piece is a challenge from a workflow standpoint. And it does take additional time for the patient. It does take additional time for the patient and the pharmacy team. So it is an administrative thing. Do we really need to have this level of documentation, or can a technician accept it? Not every state that has mandatory counseling requirements has this strict of documentation requirements. So is there a way that we can alleviate some of the administrative burden to make it better for pharmacists and for technicians and for patients ultimately?
So I get that. I agree with you. So here's my question. Don't most pharmacies today print out material when they dispense the prescription that meets all of the counseling requirements?
Definitely.
For new scripts, yeah.
So why don't we let that count as the counseling? Then I don't have any problem asking the patient if they also want to talk to the pharmacist, or if the pharmacist thinks we need to. But why are we insisting on this oral counseling in addition if we're giving them the written materials? That's a much bigger issue, I know, than what Kristen started, but.
Should we be carving out like, because I know it says new prescriptions, but the example that Kristen brought up, people that have been on medications but are just getting a new prescription for the same medication they've been on for years may not need counseling. Is there a way that we can clarify that it's really just new therapies that are prescribed for the patient? So that and that a technician would be able to, in that case, the patient responds, oh, I've been on this for 10 years, that would be a legitimate reason not to call over the pharmacist to where the technician could then document that particular situation.
And Kelly, we changed the rules at least once before, because before it had to be on every new script. Now it doesn't have to be on the continuation of the exact same. Kristen's example
Okay.
was a change in strength.
Oh,
Even so, I think it's kind of hard to determine what is quote unquote a new prescription, right? Like if someone has a new pharmacy, everything is going to be a new prescription, even if they've been taking those doses for 30 years. So I think like the issue still kind of stands in some sense. That's when a refusal is like pretty strange, right? Like, oh, hey, like this is not new to me, right? But technically you're supposed to counsel me on it and I don't want you to.
Well, and this is Mark. It doesn't prohibit the pharmacist, regardless of what we do here. There were certain things that I absolutely positively didn't want to leave the pharmacy till I had a conversation with the patient. And I don't care if they want to talk to me or not. I had things I needed them to know about. And I would mark that in a special manner. Like I would staple something over this of, this does not leave the pharmacy till I talk to the patient, or someone who's a pharmacist talks to the patient. It doesn't prevent the pharmacy from taking that action for the things that really shouldn't leave before the patient has received some additional important information that the pharmacist thinks is important.
So guys, if I redline that one section, one sentence, part of that one sentence out, that seems to address Kristen's concern.
That would eliminate a lot of what we today consider mandatory counseling situations.
Well, it would be a different strength. Oh, are you saying it would be a different dosage form in the scenario I gave? Because it would just,
So if the prescription medication has not been previously dispensed, right, to the patient, period, we take out the strength, kind of addressing your Synthroid scenario, right? Or dosage form, because it may be tablet to liquid or something of that nature, but the side effects are the same. Or with the same directions.
I don't know if I would read that and get that intent.
Because it's only required if the medication changes. If the medication remains the same, with the same strength or different strength now, or different dosage form, then counseling is not required. Because the drug is the same, it's just the directions have changed. Dosage form may have changed and the strength may have changed.
It's something.
Can you page down to the documentation requirements? Page down, Cam, a little more, please. So this is where I think we get stuck, right? Is if the patient says that nothing prohibits a pharmacist from, if the patient refuses counseling, but then we require that the pharmacist or the intern document the refusal of the counseling.
To Sandy's point, is this already allowed to be delegated to techs, given the changes in 1104? Because it says that they can't provide, they can do everything but provide counseling and clinical things.
Could we just say that consultation documentation is required? That it either occurred or does not occur? And leave it to the discretion of the pharmacist and the entity to decide how that's done? Because right here it says that the pharmacist or intern shall document.
I think it says that in a lot of sections in our rules package, Lori, but then
Mhm.
1104 kind of says the pharmacist.
We can delegate it.
Delegated, with the exception of, administering emergency meds, counseling a patient, doesn't say about documenting, conducting a drug utilization review and so forth. So there's,
Can you
Can we
share,
just remove or strike, sorry, Kristen, strike pharmacist and intern and just leave it blank, and that way.
That's what I was saying. Yeah.
Because unless you know all these sections apply to one another, it's hard to interpret when you're reading one because it's reads black and white here, but
Mhm.
to know if it meets an exception somewhere else can be confusing.
Can you page up just up to the bottom part of that last page so we can read it in its entirety? Thank you, Kim. Yeah, I think we need to take out the people, is my personal opinion.
Just in the documentation, yeah, just in G. Right. Or. Oh, I guess an F.
Yeah, that's what I'm trying to figure out is how to.
F, G.
What if we just clean it up and have one, get rid of G and just say that if oral consultation is required, that it must be documented if it was performed or not performed, and leave out the. When oral consultation is required in subsection B, there shall be documentation that the consultation was provided or not provided.
that goes back to if it wasn't documented, who's held responsible? To fall on the PIC, the pharmacist on duty at that time, or
It might like depend on each scenario, right? So for instance, if like a pharmacy didn't have the right policies and procedures for this, like maybe it would be the permit's fault versus if a pharmacist like forgot or something or overrode some message, maybe it would be their fault.
Are you looking to eliminate the documentation of who actually did the counseling?
it's for denials, right? Or both?
it's both. It says is or is not provided. So it's either counseled or refused, and documentation right now of the pharmacist that counseled or accepted the refusal.
We want the technician to be able to document who did the counseling and or if a patient refused, correct? But we don't necessarily want to remove knowing who did the consultation.
But the F would have to stay because that's the
Oh.
action.
Okay.
And G is the documentation component that we probably need to modify. So thank you, Sandy.
And these are still only for ones that require counseling.
Yeah,
And do we want to change when counseling is required?
I
Well,
think,
let's,
sorry, Kel, go ahead.
no, yeah, no, sorry, I keep interrupting. It says that even in F though, it says that that the pharmacist or intern shall
Mhm.
document. I think that maybe that needs to be reworded to just say the name of the pharmacist or intern who provided consultation should be documented, but not specify who can do the documentation.
That assume responsibility to document. We have technicians now that actually put the information on the counseling records. So we're already looking at them from that particular standpoint of the language.
So we'll wordsmith that. Did I capture what we want to do?
Yeah, can you go to that delegation portion that we were referring to? The
The
1104.
the 1104?
Yeah. Where does it say they can be delegated any tasks they're trained to do by the pharmacist, all that? Okay, as I was trying to look for that, it just seems so hidden and difficult to understand that that's what's allowed. Is there any way to I don't know, any suggestion to where that's understood? I feel like it's really difficult to find.
The scope language, like the tech delegation language itself.
Yeah, it's like this is the umbrella and it's kind of hidden behind all these other things.
The only thing we could do is there places in the rule where we could reference, or as delegated to a tech pursuant to
I
make
think
the
that-
reference back.
That might be
Or
helpful.
at the end of a certain section or something might be helpful in certain areas where we think it might.
Yeah, I think we were trying to keep away from a list of things that
Yeah.
they could delegate, knowing that practice is going to continue to evolve.
But I think referencing it's not a bad idea. It's just, not easy to find, I guess. I'll just stick it to that statement.
And even like when we talk about counseling documentation, like I don't see why a technician trainee couldn't be delegated to a technician trainee. And
Mhm.
technically the delegation language only applies to a technician.
Yeah, that's true. And excuse me for not knowing this detail, but could it even be possible that a clerk is working the the
Yeah.
register?
It's a good point.
Important though, I would think that if you didn't do documentation, which is so important to the counseling, we couldn't bring a trainee and, I mean, we can, but holding them responsible, I feel like, I guess a trainee we could.
But I think it would be, at least from how I've seen this board like respond to things before, it would be like situation specific, right?
Mhm.
So if for whatever reason the trainee or the clerk was not properly trained on how to collect this information, that could be the responsibility of whoever failed to train that person or give that person the resources. So
Mhm.
like, I think there's still a chain of custody if something goes wrong.
Or if every single prescription has a denial under a pharmacist shift, for example, that would be poor standard of care because not every prescription should have a denied consultation.
Right.
You know what I mean? If it was a one-off circumstance, you know, to me, that's much different than, you know, somebody that is willfully just not conducting counseling.
I'm not against the trainee, but I'm comfortable with it being a technician.
And I'm comfortable with it being a clerk. I mean, personally.
I think like the thing that I'm kind of like I keep going back to is like these are just conversations that keep happening, and I used to work in a you know setting in which some people would be reaching out by phone. So there's not even like a physical like way to like try and get somebody to stay in the store while you grab the pharmacist. It was a very real thing where someone could be like, oh, I'm going to transfer you to the pharmacist because you have a question about this med. And they'd be like, oh, no. Like if that's a customer service person, like what's to do? Like it's a very real scenario that happens all the time. It's not an offer. It's not documenting a refusal. That person is just like, no, like I'm about to hang up. And I don't think the rules address that right now, or when someone just walks right away.
That's why I hold their meds hostage.
Yeah.
You can't have it. What about, isn't it a little bit different expectation when it's like a mail order or, you know, a pharmacy where you're not face to face?
But yeah, but if there's a counseling thing that kind of goes on, either the patient asks for it or we want to proactively counsel on something and then they refuse, what if it's the customer service person that they're speaking with?
Well, Roger did state that it's all printed out for the patient.
Yeah, it is. But like, you know, like if we want to call and we're like, hey, you have I don't know, antibiotic that you should stop taking your statin for a couple of days. They don't want to hear it. And they hang up on the clerk. How can the pharmacist document that?
I think that's why a lot of states are going to standards of care. I think some
Yeah,
of this
I
stuff
agree.
is like, you know, each situation is unique, and I think you do your best to take care of the patient. What would the average person do or pharmacist do in that situation? And I think there's nothing you can do. Like you would have to document that the patient hung up and refused consultation, and hopefully that's not going to be a violation because you can only do so much.
But I think Emily's saying who documents it.
I think there should be able to be a clerk or a trainee to do this. It was my misunderstanding or my mistake to like just fully reference this rule because I forgot that they're not addressed in it.
But Emily, on the mail one, you've met the counseling obligation when it's mailed. There's no obligation to document the phone call. I mean, you can, but there's no legal obligation thereafter.
No, yeah, I agree. I was just talking about when like there's an emergent counseling type thing, right? Or if someone's like, oh, hey, they call in, they're like, I have a question, and they don't want to, then they refuse to talk to the pharmacist or et cetera. So kind of like the counseling scenarios that happen on top of the written counseling. But I agree with you. Is what we're hung up on right now, the fact that the documentation can be delegated to a trainee and a clerk, since that's not written in the rule right now.
And I think that's what I noted, wordsmith to document who performed the counseling, but allow any pharmacy personnel to document.
That sounds good. Any pharmacy personnel, yeah.
I think to address the clerk situation, we're moving that pharmacy technician trainee to a registrant, which means, you know, I don't even know if we need a clerk. We've had some clerks diverting controlled substances and we have no authority. So at least now and it's minimal requirement, right? To be 18, you don't even have to have a high school diploma anymore or a background check by the board. So anybody can be a pharmacy technician. We might as well, we
Oh, I
might
see.
want to think about the clerk position altogether because anybody can get a tech trainee license for 3 years.
Hey,
I think
Cam, let's ask that question. I thought clerks weren't allowed into the pharmacy system itself, and isn't that where most of this documentation takes place?
That's
Or is this
correct.
point of
Today,
sale document?
yeah, we have outlined, and it was addressed many years ago about the responsibility of a tech. Even if they get a refill, I think they jot it down on a piece of paper and give it to
Right.
registrant or licensed individual that can access the computer system.
Yeah, that's fair. Sometimes they're just the prime, like, yeah, they have to then transfer this information or the call to someone else.
Yeah.
Um,
And that was outlined over a decade ago.
Yeah. There may still be a scenario in which clerks are like necessary, but maybe not in the senses that I'm describing, right? Like.
Yeah,
something
I
that
don't,
might not be handling drugs or whatever.
I mean, lots of pharmacies use cashiers. I mean, and it still takes time to issue a license. So it could be a detriment to the public to not be able to have somebody back there to help the pharmacist in the time frame in which it takes to get a license too.
I think
our
it's
major-
important, sorry.
My main hangup today with licenses are background checks, right? If that's gone, then there's really nothing that holds up a license. Right now, we're processing a complete app, a technician that's nationally certified within 2 weeks. And they have hoops to jump through. When we move to registrant to not have any more hoops, other than provide lawful presence in this country, a photo ID, and proof that you're 18, you're pretty much good to go.
When does that take effect, Cam? Because I thought that was like June of this year.
Yep, July 1st is when it starts, new fiscal
But
year,
then they have 3 years, I think, to become
certified.
certified.
Yep.
So it potentially would solve a little bit of a hole for a clerk coming on, but then they would have to become certified, so you couldn't remain,
As a tech trainee, correct.
yeah.
And there's no more like waivers or anything, right? If somebody can't pass.
No,
Yeah.
thankfully.
Just keep in mind that the majority of the retail pharmacies right now, their counseling documentation is electronic. There's only one major chain that still uses a paper documentation that I'm aware of.
So we'd want it to be a technician trainee or a technician. Okay, well, we have it as pharmacy personnel, right?
I think that's what the task force members were moving to, yeah.
And then I was just asking that you reference this, so it's understood. Kind of as Kelly was saying in the previous section, if it's not all put together, it's not understood what's allowed sometimes.
Well, we still have to draft. Put this in a format that's, you know, legible and comprehensive, and then we can revisit those sections that probably need to further clean up. This is still pretty messy, so I don't know what the end is gonna look like by the time I'm done wordsmithing everything. Any other discussion?
That was the held over business that I had noted.
Lori, before we move on, can we take a 5-minute break?
Yeah. Maybe come back at 11, actually.
Okay.
Sounds good. Kim, do you want to see who's back?
Yeah. See you, Lori. Ms. Nair,
I'm here.
Mr. Dang is still out. Mr. Pond,
Present.
Ms. Howe,
Here.
Ms. Fine.
Here,
Okay, Ms. Patel, I believe, had to log off. Mr. Boson,
Here,
Mr. Morris. Mr. Morris. Ms. Almer. Okay, I heard her, very quiet, but I heard her. Keep an eye out for Mr. Morris, but we do have a quorum, Madam Chair.
Looks like he's back too.
Roger, you there?
I see him.
Maybe his volume's off.
We can't hear you, Roger.
Roger, can you hear us, buddy? I don't think he can hear us either. Let me ping him real quick. Roger, you there, buddy? Hey, it looks like your speaker and mic may not be working. Sure, back. All right, he's gonna log out, log back in. So any more discussion on this subject? All right. Any other topics anybody wants to revisit before we move on?
Pam, can we look at the definitions again for the hospital? They have a term repackaged drug, which repackaging to me is a manufacturing term. And we already defined prepackaged in 110, so I'm not even sure that we need that at all.
Okay. Able to see my screen, everyone?
Yes.
Is this what you're talking about, Sandy?
It is. I don't think we actually even need it here since we already talk about prepackaging and definitions and also in 402.
Any thoughts from the committee? Roger's just dialing back in.
Yeah, I think Sandy's comment makes sense here.
Hey, I'm back. Sorry about that.
Yep, we got you, Roger.
Okay.
So Sandy's discussion is back to the hospital definition section, the definition of repackage, she doesn't feel is necessary. So I was just gathering thoughts from the committee. All right. Any other thoughts, Sandy? Any other definitions we need to revisit?
No, that was the only one that came to mind to me today.
All right. So guys, again, this section with the different fonts, different formatting was not in the original packet. I was reviewing it, identified that we didn't have it. For some reason, it didn't transfer over, so I started transferring it. But now the question is, have you had a chance to review it and gather your thoughts around it, or do we address it next time?
So
I've reviewed it, but I would not profess to be the top expert here. And I know we lost one of our hospital individuals, so.
I mean, this one to me seems pretty straightforward. I don't think we need much modification there. You just can't operate prior to receiving a permit.
What is the definition of professional? What's a professional? I consider myself professional.
Are you in the next section, 653? Okay, but this is fine, right? No change there. R423, 652.
I don't see any issues. I haven't cross-checked like the references or anything, but I assume that they're correct since that's what they are today, right? There's no changes.
Makes sense to me.
Yeah, I don't see any changes there. All right, so R423, 653.
So yeah, the header to me it's throwing me. So personnel, and then the choices are professional or technician.
Query, hang on a second, Kristen.
Is there a reason why we have to have the director of pharmacy statement in there? Is there like something for like Department of Health Services or JACO or something like that? Because why do we have the term director of pharmacy and the pharmacist in charge? Because it seems like it really means the same thing.
Oftentimes they're separate.
Yeah, they're two different individuals. They don't, PIC doesn't have to be the director.
Hey, Cam, I think you started to ask this and maybe we were all going to go through it, but given we have a new member on the committee and she's hospital, I'm happy to defer to Matt, but I'd love to have those kind of questions answered. And maybe we're better off doing this one when we have both of the hospital people here.
No, that gives me a little chance to research professional or technician as well, Kristen.
And then I'll also throw out, there's an awful lot of stuff in here that is duplicative of what's in community pharmacy. I don't know that we have to have it twice. If there's some way to have some standards generally, and then some just the unique things to community and hospital.
And Cam, the professional may come from a different part of the code. It's healthcare professional is defined there as a healthcare provider who is licensed or certified pursuant to this title to dispense or administer prescription drugs. So that may be, professional may be used to define the people who dispense or administer prescription drugs.
I mean, outside of my own feeling on it, I don't know that generally people would understand what's being conveyed.
And I don't think professional independently is used in most places. Usually a health professional It's those two words combined that's typically used in most sections.
Yeah, that's how it's used in the section I found. Healthcare professional, 3 words.
How about pharmacy personnel? And then it talks about who does what below it.
Pharmacy personnel, we defined earlier.
Hospital pharmacy personnel.
No, I think it's in the general definition, pharmacy personnel.
Well, this is going to be put on hold anyway, right?
Yeah, I think it makes sense to have the experts discuss this section as. I know we have Matt, and Matt's got a wealth of knowledge, but I think 2 heads are better than 1.
I don't disagree.
No disrespect to you, Matt. I think you could have added value, but. Let me move forward past this section.
I think I know why that says that. It's about personnel generally, and it says professional or technician. And I think that they're trying to encompass like the term pharmacist within professional and like director of pharmacy, because could those be like 2 ways? But I don't agree with the terminology. But I'm just guessing that's the intent. But yeah, I'm good to move on.
I agree with Roger too. I just think I just saw security requirements and things go by that we've already addressed in other areas.
So moving on to R423-671, general requirements for limited service pharmacy. In this, in section B, Lori had noted scriptive, too prescriptive. Will limit waivers. So again, this is requirement of minimum area, size of a facility.
Yeah, I agree with this, especially if now we're going to be slotting a non-dispensing pharmacy under this. It's probably not necessary to have a square footage requirement there either.
And I think we addressed this earlier. So wordsmith it accordingly as far as security, what kind of security is required for a type of business they're doing and equipment needs. So moving on to R423-673, mail order pharmacy. Again, the square footage is being removed.
What's the purpose of the limited service mail order anymore? As compared to just a limited service? Or even a community that just does mailing. Most of this is square footage.
Yeah.
And years ago, it had different rules on technician ratios, which are meaningless anymore.
Do we even have any of these permits out there?
We might have some.
I think some mail orders have these, but it again, it might kind of be like an artifact type deal. That was the permit available to them or best for them at the time.
And it was a big deal when the technician ratio was different.
Your thought, Roger, is this entire section even needed?
I'm not sure it's needed. I mean, the biggest thing they aren't from a community is they're just not open to the public.
Right.
I mean, correctional, I understand is different. Nuclear, I understand is different. But
Sandy, do you know the history of this? Do you concur that we can probably get rid of it? I mean, I see Roger's point that it is just talking about space and stuff like that.
I would think that other than making sure that they have some availability for the patient to speak to a pharmacist, I can see that, needing to stay. But the rest of it, no.
Is that already included in limited service pharmacy?
No, I think it would be the section F that talks about having toll-free
Yep.
telephone service for communication with the patients.
and maybe that's all it is when it's done. I mean, I don't have any problem with that rule. I'm just trying to figure out where we put it.
All right, so we agree that A is probably not needed.
Mhm.
B is in line with A almost, it's more space related.
Yep.
Here we can use that generic language we had before about security.
Yep, I agree with that.
We might just need to double check the cross references though, since we've gotten rid of some of the sections in there.
Yep.
On D, didn't we change this to be the permit and pharmacist in charge if we're keeping D? Oh, no, I'm sorry, E. To ensure that there's. Oh, I don't know where I read it. Ensure that there's policy and procedures. I keep trying to scroll. On your page.
I think the one that Sandy called out was F, which was the phone hours.
Maybe we already took out what I was looking at. Oh, no, it's G. The pharmacist in charge ensure that there's written policies and procedures. If we are keeping that, I thought that we had changed this to be the pharmacist in charge and permittee is in charge of that. Or we took out pharmacist in charge and put permittee. I think we maybe put both.
Is this the, oh, sorry, I didn't mean to interrupt you.
I was just saying.
I'm gonna ask about like if this is the only permit type that requires all these policies, or like does hospital something need need something like this too?
Yeah, it's listed later on that hospitals have their own policy, and I almost want to just have a similar general statement saying you
Yeah.
shall have policy procedures outlining your practice, right? Every aspect of your practice and function.
Yeah, I like that idea. This was always like, it was an interesting part of the inspection because like policies for prescription orders could be like 25 different policies. So it kind of became like a lot of paperwork just to go like check.
Trying to remember, do we have policies and procedure requirements like this for a community pharmacy?
I don't think they're that expensive. I don't think they're this specific.
With the exception of the drug delivery stuff, number 12, in section G, isn't everything else relevant to the practice of pharmacy? Either we think it's good or bad for everybody? Not just mail order?
Yeah, I mean,
Or maybe the assumption was a community was like one owner and they didn't need policies and procedures because they had their head, but a mail order was going to be bigger.
I like how Cam put it, just specific to your practice.
Right. So if you deliver things, you need to have policies and procedures for delivery.
Right.
If you compound, you need to have policies and procedures for compounding.
If you don't have controls, you don't need policies for controls, right?
Okay. We'll try to eliminate all that and make it a general statement. Any other thoughts on this section?
This section would not remove the ability to provide written counseling for mail, right? That wasn't part of the purpose of this in the past. Is that in the counseling section? Because I'm trying to scan it right now.
The written information requirement for meds that are delivered would be in 402. I think it's section I.
Awesome, thank you. Yeah, then I'm good.
Okay. R4 2023 701.04 long-term care facilities. You can see there's some stuff redlined to simplify the language a little bit.
I have a comment on this one. This is a dispensing system, not a distribution system. And the rule was based on the requirements in 21 CFR that the DEA put in place. So the definition for an ADS came from, I think it's section 1300.01 in the CFR. So that's what this rule was intended to cover. It's not the same kind of system that you see with the automation, for instance, in a hospital setting. This particular automation actually dispenses, counts, packages, puts a patient-specific information on the packet before it actually is dispensed from the system itself.
Sandy, is that like that TV system that's been before us?
The QB system isn't that just a storage system for unit dose packaged medications? The dispensing systems that I'm familiar with, basically they hold canisters, very similar to what you might see with a Uyama, et cetera. But then they dispense it in unit dose packages, and on that package will give you all of the patient labeling information. So it will give you the patient name, the drug name, strength, directions for use as it's dispensed through the system itself.
Gotcha. So like a mechanical counting device in a community pharmacy.
Correct, with just the added information that it adds the labeling requirement to the package.
Yeah, like a strip packager or something, automated tablet packager.
I will say under section B, number 3, the DEA doesn't prohibit those dispensing systems from having Schedule II stocked in them. That was put in place that when this rule was originally drafted by the last task force, just because that was the deviation language that they had out there in place prior to the rule being put in. But you could include Schedule IIs in the system if that's what you wanted.
Well, I think that would be preferable than having like a tackle box or something. There'd be more accountability for that in the system than those types of things.
Well, it's not intended to be anything but a profile system. It's not utilized as an emergency drug supply. So they would have to, if they have tackle boxes for emergency drug supply, that's a separate system itself.
Okay.
I think this is like a patient specific, like unit dose type thing.
Mm-hmm.
I'm
And we
trying to
don't have a,
remember if I used to put C2s in strip packages in long-term care pharmacy I worked at in another state. I feel like we did, but that was.
But if it's not prohibited by the DEA, I don't know that we should prohibit it.
Yeah, I agree with that.
and there's only 3 or 4 of these dispensing systems out there. And I do believe that they've been in front of the board for deviations to add Schedule IIs.
I'm supportive of removing it.
Same here.
Any thoughts on C?
I thought we added to this one already.
I'm sorry, what was that, Chris?
I thought we'd added the pharmacy permittee to this already, didn't we?
This one's already there. This is existing language. So it says a pharmacy permittee or pharmacist in charge of a provider shall.
Okay, I looked familiar. I thought we'd already gone over this one.
Yeah, no, the language in black is existing language.
Can a pharmacist delegate that task, some of these tasks to a technician? Like review of policies? Something I do. Not in a pharmacy, but it was under C. Revise policies, procedures where required. I guess it doesn't say that you cannot, but I was just curious.
If you're reviewing the policy procedures, I think someone still has to sign off on them. That's ultimately responsible.
Yeah, it would still be under their supervision, so, yeah.
So under number 3 here, drug stocking procedures that include the following, and Lori made a note about, can we include other healthcare professionals outside of our jurisdiction, i.e. nurses? And we can, the only concern is, how do we hold them accountable?
And I think that's I made that comment because that's a request that we get pretty frequently.
Yeah, yeah.
So just to point out under A, under the drug stocking procedures, when the rule was drafted, they were trying to hit both any type of system that might be out there, both those that have removable canisters and those that don't. I've never seen one that did not have a removable container or canister to it. But if you would, then that might be something that you want to consider as to who can fill that, because it would be a canister type system within the facility itself.
Yeah, so it leaves the pharmacy in that canister sealed, that's tamper resistant, and all they have to do is load it, right?
That would be for the B, the removable containers. Those are filled at the pharmacy and sealed and sent to the facility in which they can put them at any place within that system generally, because they read the barcode, or not barcoding, but the technology chip that's on each of those canisters. But A is a non-removable container, which would be fixed at the facility.
Gotcha. So I think Lori, I think the B, I think anybody can then load it. I think A is the problem of if something was done wrong, who do we hold accountable?
Aren't we holding accountable the permittee on this one for if something happened there? We may also make a referral, I'm making this up, if the nurse was the problem, to the nursing board, but we don't have the ability to go after the nurse. It could only be the permittee and or pick.
But I think for the sake of argument, Roger, if we say any other healthcare professional can load this thing, and we allow that practice, how could we hold a pick and permit holder accountable? Because the
Well,
practice is allowed, and then it's the other healthcare professional that messed up.
As I understand these systems, the only way they mess up is they steal or divert. They can't misfile.
In B, they can, because I think it's monitored by chip, so it doesn't matter what area they put it in, the machine will calibrate and know what drug is in what
Right.
section. But A is you're filling, you're going on site, I think, and filling the container yourself,
Filling the canister.
filling the canister.
I'm not aware of this for all systems, but I know that the systems that I've worked with, the canisters can only, are supposed to only fit through the medication that they're calibrated for. But I'm not sure if that applies to all systems.
Yeah, exactly. I think that's why we got the two processes. So I'm okay with B, having anybody load those containers because those containers are sealed, almost like giving a patient a bottle at this point, leaving the pharmacy.
Do we want to be explicit and say, if you use another healthcare professional, it's at your risk because it's not appropriate supervision to the permittee and pick? I mean, to say it that explicitly?
I think we would have to if we want to go in that direction, yeah.
I'm just trying to think of an analogy. We have people who divert from pharmacies today who aren't pharmacists or pharmacy techs. We might have a delivery person who gets in and isn't supervised appropriately, or a computer person who isn't supervised appropriately. We hold the permits and picks responsible there.
Yeah, but I think we have it spelled out that they fail to control the controlled substances. So it is spelled out that they are responsible because they didn't control the environment. I don't think we have it spelled out here.
Okay, so I think we need to spell out if we're giving that option.
Yeah, absolutely.
Also, I think a technician could do this.
Yeah.
Would it be, could we address both A and B by like having a general statement and then having a carve out for if it has like specific technology? I don't know if we need to do that, but and it doesn't address the personnel thing.
Well, if it happened today, we would hold the permit holder responsible and it would turn. We would tell the nursing board, right?
Well, the thing is, we haven't allowed it to happen today. And I'm not sure if the nursing board has anything in their statute rules
Yeah.
about professional conduct for loading a machine wrong.
We just get a fair amount of requests for this.
Yeah.
So just so I understand, can the nurse take the medications out of this machine? But we're saying they can't put it in?
Correct. It falls into the administration, then once they take it out of that system, then it's out of our jurisdiction and their jurisdiction, and they could be held accountable for their actions at that point.
Should we reach out to like the nursing board and ask them their thoughts? Someone there might have a thought on it.
that good? Guys, did I lose you?
Think so.
Nope, you're good. Sorry, we were just like nodding quietly.
So if this is saying a provider pharmacy is capable of producing a report of all transactions of the automated, do we really need history and this?
What's the provider pharmacy again?
The pharmacy that's, providing those canisters to that machine.
Okay.
They should be able to produce all transaction reports. But do we need to include? History, date and time? I think it's implied in all transactions, but
I agree with that.
I agree.
Yeah, I would change distribution in that sentence to read dispensing.
just my thoughts, guys. I don't know if all that verbiage is needed.
I would agree because this other stuff is going to be required anyway with DSCSA, like expiration dates and lot number and etc.
Yeah.
I agree.
Thoughts on this, guys?
Kind of similar to your point before, Cam, do we need to have all this specificity, or should we just say that they need to have policies and procedures in general?
Encompass their practice setting is how we've done it before.
Yeah, I'm sorry. I skipped over. I was looking at F down there. I'm sorry.
Yeah, I'm still up here. If we're okay with that, I'll move down to F.
Yeah. Almost seems like number one would be fine with them. A, B, C, D. But unless we think it's important to have those things, I don't know.
For those familiar with this, does the unit itself have guidance issued saying it should be calibrated every so often? And I would think that they would have some sort of guidance for the folks that own the units.
Yeah, I mean, all the automation that I've worked with has had like very specific guidance as to how to care for it. It's kind of interesting because it's like I don't know if documenting all of this stuff is like implied elsewhere. Like you have to clean it, like because adulterated meds are not allowed.
Absolutely.
Yeah, but I'm really not sure like how hard it might be to kind of correlate that.
Weren't we discussing this before on how often they had to be validated?
Yeah, I think that like I almost feel like that should be like specific to the machine or the manufacturer or whatever. So it might not be 3 months, but in terms of like documenting that you care for your machines, I don't necessarily think it's a bad thing to have that documentation generally. Any like upstanding pharmacy, I feel like would care for their machinery.
Is it a recommendation by the manufacturer, or is it you shall do this every 3 months? Or because if it's a recommendation, then there's that argument. It's just a recommendation. There's nothing that says I have to do it.
Yeah, that's it. It's a great point. I don't know if it's something where, like some things, if you like maintain it, then you can get it serviced, like the warranty, but that's really not a mandate.
I mean, we can put something in there and maintain the dispensing system according to manufacturing standards or something like that.
Yeah, I think that's wise, as opposed to putting like the 3-month thing.
Yeah.
I figure most of them are probably some different number depending on the technology.
according to manufacturer recommendation.
Implement an ongoing quality assurance program and monitors performance of the automated.
That way, even if they say it's only recommended, you're saying then follow those recommendations.
We can wordsmith this, but at least I get the. The gist of it. And I would think they would automatically produce something for downtime and malfunctions. That's in their best interest. I don't think they want a unit to stay down. So I'm not sure if that's necessary.
Yeah, I agree with that.
Agree.
I think any long-term care facility would almost like require that in their contracting or pharmacy selection generally.
And that makes sense. Yeah, I think that is a requirement for records. Miss Laurie, I think we're starting to lose people, so maybe we want to call it. It's like
Yeah.
it's 2.
Yeah, I think that sounds like a good place to stop. Thanks, everybody. We got a lot done today.
Great.
We can adjourn at 11:53.
Right.
Have a
Yeah.
good holiday weekend, guys.
You too.
Take care.
Bye.
Thanks, folks.